Now we're going to talk about part two of the public health approach to suicide prevention. And again, public health approach meaning interventions that are aimed at people in general, the population at large, as opposed to the clinical, which would refer to dealing with one specific individual or a small group of individuals. So many of these approaches have come, that I talked about in part one, come under the category of means restriction or method restriction, finding ways to try to keep people from lethal means of killing themselves. But not all public health approaches take this angle. Another example is the economy. Now, obviously it's hard to make changes to the economy as a whole, but there's a lot of evidence, not conclusive, but a lot of evidence that one of the major impacts on the suicide rate, for people in general across the country, is the state of the economy. And in general, it's kind of a rule of thumb, but that across the 20th century, roughly a 1% rise in the unemployment rate leads to a 1% rise in the suicide rate. We'll obviously going to have to see what happens with the pandemic now and the pervasive unemployment. We'll have to see. Although there are some mitigating factors, perhaps. We'll come back to that. Another estimate was that during the housing bubble crash in 2008 and 9, that in the U.S. and Europe, 10,000 additional deaths by suicide that probably would not have occurred except for the change in the economy. Another obvious comparison would be to look at the Great Depression in the United States, which was in the early and mid 1930s, well, most of the 1930s. And you can see on the slide here that in 1932, the overall U.S. suicide rate was 22.1 per 100,000 per year. Now, remember we talked earlier, the current suicide rate as of 2018 in the U.S. is 14.8 per 100,000 per year, so almost half again higher back during the Great Depression. We can also see this slide shows the unemployment rate and the suicide rate from 1979 to 2009, and I'm not even sure which line is which because you can see how they're so correlated with each other. So that gives rise into the obvious question is, can we have economic policies that would reduce suicide? And especially, again, we're talking in the current days about the deaths of despair with the high rates of suicide among middle-aged and the young elderly, mostly white men, but others as well. And so a working paper from the National Bureau of Economic Research suggests that is possible, and they studied the wages and the earned income tax credit in different states. And they found that in states that had a higher minimum wage and had a higher income tax credit, that they had lower non-drug suicides, but no change in the drug-related suicide. Okay, so that kind of belies the idea about all deaths, despair being overdoses, but nonetheless, deaths by gunshot, for example, and by hanging went down in states that had these economic benefits. Another study found the 10% raise in the minimum wage, same study, reduced non-drug suicides in non-college adults by 3.6%. A 10% raise of the EITC reduced suicide by 5%, but there was no impact on college educated. So it had most of its impact on people who did not have college. And they projected that increasing both of these, increasing minimum wage and increasing the earned income tax credit, could save as many as 1,200 suicides per year. So you can see the economic impact on the suicide rate. Another study looked at minimum wage across different states and found that for states that had $1 higher minimum wage had a 1.9 decrease in the state suicide rate, and they tried to control for many of the other important variables. And so a 1.9% decrease in suicide rate in the whole U.S. would represent 8,000 fewer deaths by suicide. So, impact of economics. A slightly different angle on it is social welfare and income equality. And here we're looking at a comparison between the U.S. and Europe, where the suicide rate increased by 24% in the U.S. between 2000 and 2012, but during the same time period, the suicide rate in Europe went down by 20%. And these researchers, Steve Stack again, who I know, correlated it very clearly with social welfare spending and income inequality. Okay, so his thesis, which is backed up by this data, suggests that less of a social safety net, and we've seen, in fact, in recent times, that's even been cut down even further, and more income inequality leads to higher rates of suicide. Now, some other examples would focus on guns, does focus on guns, common sense gun laws, such as how in 2006 the Israeli Defense Forces began not letting soldiers take their rifles and guns home on the weekend, and since then they had a 40% drop in gun suicide and no increase in weekday suicides. Okay. There was a mass shooting in Australia in 1996. This has been in the news over the past couple years in discussions of gun control, especially automatic weapons. Well, in Australia, they had this mass shooting, and after that, automatic and semi-automatic weapons were banned. They had a buyback. They paid money to turn in their guns. And since then, the number of gun suicides has dropped by 50%, and no increase in other methods of suicide. And this graph shows firearm suicides in Australia from 1970 to 2006, a dramatic decline. In the U.S., total suicide rates by state are correlated with gun ownership, and stricter gun control laws in states are correlated with lower suicide rates. More specifically, some states require background checks and mandatory waiting periods, and this study by Anestis et al. Showed in a time of increasing suicide, states that had these two laws had a decreased rate of 0.76 per 100,000. States that did not have these laws had an increase of about 1 per 100,000, and they controlled for some other variables. Another study showed that household gun ownership was highly correlated with youth suicide rates. And in a state-level analysis between 2005 and 2015, that correlation held up. And for each 10% increase in gun ownership, the youth suicide rate was 27% higher. Okay, guns and suicide. Now, again, this is correlation, not causation, but there's so many things that point in the same direction that I'm willing to say I fully believe that what the consensus of the literature is that simply having a gun in the home is a major risk factor. And you can see from this graph the gun deaths, not just suicide, but gun deaths, although keep in mind, many more gun suicides than gun homicides or gun accidents. That gun ownership is correlated with gun deaths, and you can see state-by-state analysis here with some of those mountain states that we talked about before, which having high levels of gun ownership: Montana, Wyoming, Alaska. Some of the highest rates of gun ownership and some of the highest rates of gun deaths. Or, maybe this is just culture. Maybe this is, men primarily who want to own guns are more prone to suicide or more prone to something. I don't know. By culture, I'm referring to, and we're going to come back to this later, about conventional masculinity. So one of the best, probably the best, community-wide suicide prevention programs ever set up in the United States, and actually across the whole globe, as far as I know, was instituted by the U.S. Air Force in 1997. And this program, which had a dozen different parts to it, It had training, it had education, it had ways for enlisted men in the Air Force to get help without it impacting their service records. They had special confidentiality because in the military, basically, if you go see a therapist in the military, it is not confidential. And so, of course, people don't go because they're afraid it's going to interfere with their career. Well, they changed that, at least in certain areas in the Air Force. And one of the major targets that they focused on, which started at the top, these things have to start at the top, was trying to change the culture of it's weak to ask for help. And so they tried to change it through a variety of ways to the idea that needing help is normal and that it takes courage to ask for help when you need it. And they have been somewhat successful in changing the culture, a macho military culture, changing it to some extent toward this different set of attitudes. And over that time, they have dramatically reduced the rates of suicide and accidental death and homicide and family violence, domestic violence, in the U.S. Air Force by primarily changing this cultural aspect about asking for help, and that it does not indicate weakness. And as you can see what I wrote on this slide, this is the opposite of conventional masculinity, and we'll come back to that. We're going to talk about that a little bit more later when we talk about individual approaches. Other public health approaches that have been found to impact the suicide rate is higher alcohol taxes, fewer liquor stores, zero tolerance for underage drinking, increased taxes on beer even is associated with lower suicide rate, at least in young males. From a different angle, a recent study in JAMA Pediatrics focused on the differential rate of suicide attempts in the states that have marriage equality and the states that didn't have. Now, this is obviously before the Supreme Court ruling. So some states it was legal for gays and lesbians to marry, and in some states it was not, up until 2015 or 2016. And what they found was states that had same-sex marriage laws had 14% fewer suicide attempts, which represented 134,000 fewer suicide attempts in those states where gays and lesbians could marry. And basically the authors felt that this was reduced stigma, that more acceptance and reduced stigma in those states led to lower rates of suicide attempts. Some other interesting population level issues, some of which we might be able to intervene, some of which would be impossible. And this is a puzzle that I don't think, from what I've read, anybody understands. Lithium in drinking water. Now, as you know, lithium is used in the treatment of bipolar disorder, and lithium is one of the few drugs that's actually been shown to have a suicide preventative effect. However, the amount of lithium in drinking water is much, much, much lower than the medication lithium. That it is the same, but it's much, much diluted in the drinking water. And still, a study of 15 counties in Alabama found that there were lower suicide rates in the counties that had a higher percentage or proportion of lithium in the drinking water. And this was true for the whole population, and also for if you analyzed males. If you analyzed females, it did not hold true. And they controlled for some of these variables that are important. I don't understand that. I don't think anybody yet is suggesting that we spike the drinking water with lithium, but it's an interesting thing to keep in mind. Even more puzzling, maybe, or surprising, is there appears to be at least two studies. That doesn't make it the truth, but two studies that suggest that higher altitude is associated with suicide. So controlling for a lot of variables, and this took place in Colorado or Utah, I can't remember, that they controlled for the proportion of the population over age 50, the proportion of males, the proportion who were white, all these which are risk factors for suicide, household income, population density, gun ownership, that they found that the counties at a higher altitude in, again, either Colorado or Utah had a higher suicide rate, both with guns and other methods. And so the thinking is it possible that anoxia, lower levels of oxygen in people's blood, contributes to the suicide rate? One other analysis of South Korea found a similar finding, that higher altitudes had higher suicide rates. So now it's interesting, actually, though. I don't have time to tell you in detail, but then in conjunction with this study, I read an article where people who live in some of the resort areas and the ski resorts in Colorado and Utah argued that it was much more of a social and cultural phenomenon that had to do with people who moved to those resort areas 20 and 30 years ago to become guides, to work at the restaurants and the bars, to become ski instructors and things like that. And over the years, as they've gotten older, these places have become more and more a place where only wealthy people come, that they can't afford to live in the towns where they're working. And that they feel, according to this article, which interviewed a bunch of these people, that the ski instructors and the people that work in these towns really felt a kind of depression and pessimism about their own personal futures, because of surrounded by the wealth that they see around them, and yet they're still barely making minimum wage, barely able to support themselves. So I don't know, maybe the jury is out. Another interesting one, and perhaps counterintuitive, is that people who are underweight have an increased risk of suicide, and people with a normal weight, or who are overweight, or who are obese, very overweight, have a decreased risk of suicide. And this is controlling for eating disorders, for socioeconomic level, demographics, smoking, alcohol, exercise, everything. And this 38 studies, a meta-analysis of 38 studies has found this. So again, I have not read anybody with a plausible explanation. And it's only about deaths. The correlation is completed suicide, not suicide attempts or suicide ideation. Interesting. I don't know that there would be a very good way to intervene with that. And here's a final one that does really present a way to intervene, several ways to intervene. And first is, believe it or not, blue lights in subway stations. Two studies in Japan compared subway stations in which blue lights were installed. And these blue lights were installed specifically. Here's an example of one blue light, and here's an example of a station that had many blue lights. They were installed specifically to try to prevent suicide, thinking that they have a calming effect. And a study comparing 11 stations with blue lights and 60 stations without over a 10-year period found an 84% reduction in suicide by people jumping in front of the subway trains in the stations that had blue lights. There was no increase in other stations. So there's the blue lights. And then also platform screen doors in subway stations, which they have a number of places in China. So 94 metro stations were studied in Shanghai between 2008 and 2017, and some of them had half-height barriers like this, and some had full-height barriers like this. Now, this is a subway, but you might recognize they have this at the People Mover out at O'Hare Airport. You know, the little tram that goes out to remote parking has these kind of, when you go into the station, you can't access the tracks. The train stops and then the inner doors open before the train doors open. And what they found was with half-height barriers, suicide was reduced by 60 to 80%, and with full-height barriers, perhaps obviously, the suicides were reduced to zero. And strikingly, no increase in other subway stations that didn't have any barriers. So once again, apparently people don't have a plan B. If you can prevent suicide on any given occasion with any given person in any given method, then that make a difference for their whole life. You know, remember, I think we have talked about this already, only about 10% of people who attempt suicide go on to die by suicide. Now here we're talking about preventing even the first attempt, but same idea, that if you can stop a person before they make an attempt, then the odds are really good that they will not make another attempt and that they will have a full life, going forward. All right, so I think these are really interesting concepts to think about. Okay, so that's my presentation in two parts about the public health approach, and now we're going to turn, to the real focus of the class, obviously, which is the clinical approach to suicide prevention. All right, so I'll see you next time.